The following podcast was recorded at the ANZICS Safety and Quality Conference 2014. Rapid Response Teams. Judy Currey discusses educating ward nurses.
So I'm Judy Currey, for those of you who don't know me, and I have my current role as the Director of Postgraduate Studies at Deakin University and a clinical role at the Alfred. I think that Daryl has asked me to speak about these. So Daryl was very organised, and this session is obviously around educating nurses, but it would have been just as appropriate to have been in this morning's session, because I can really stand here and say what they said this morning, Alex, Ken, Imogen just now, it's ditto, 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 ditto. So for everything that you heard this morning, add it in, and I'll try not to be repetitive about the sort of things that I'm going to say. But Daryl asked me to talk about what should nurses know, who teaches it, when's it taught, what's the role of us as ICU clinicians, and I've added in individual accountability, because as far as I'm concerned, that's actually the most important thing I could speak to you about today. I thought on the right-hand side there were some ideas that came to me when I was thinking about this, and I'll come to some of those. But in terms of what we should teach, obviously the classic knowledge, skills, attitudes and behaviours are important. So I'm going to start with with a framework that I found, and this was originally proposed by McQuillan, and Wilson sort of added to it, and Deb Massey and Leanne and Wendy put a paper about it in ACC in 2008. And they really said that if we're going to educate nurses properly, these would be the areas we would want to address. So I'm going to take each one of those and talk about how my role as an educator and your role, all as clinicians and educators of other colleagues, could address some of these issues. And secondly, put up some of the barriers or some of the changes that I'm aware of that I think impacts on education. And so, as Imogen just said, education alone isn't the solution. There's a whole lot of system processes in place, and we have to actually educate our nurses to work in the new system. I've been saying for years, hospitals are not teaching environments, they're performance environments. And the expectation of our critical care nurses, our ward nurses, to perform the instant they get in is quite phenomenal. And as a hospital nurse of 25 plus years, I was appalled when I went to university to find that it's the hospitals that don't let the universities in for nurses to get clinical experience. I was told by my own hospital that they couldn't possibly have first years in the hospital because they were too acute. And I said, you've got no one here who needs their bed made, a shower done, a walk, their dignity maintained. I mean, it was extraordinary. So if our nurses don't get into hospitals in the first year, and I'm at a university where our nurses do get into a hospital in the first year, and they go in their first semester, they come back after they've been taught vital signs and said, now I know what you're talking about. No amount of simulation, videos, YouTubes or anything else actually prepares them for it except doing it. So for those of you who actually have students come and work with you, someone said it earlier, please be really kind to them, and I'd also ask you all to not be judgmental. And in my talk today, I've been asked to be deliberately provocative, so I will, but I'm not putting any judgments on it. The first thing we really have to do is talk about the basics. And without anatomy and physiology and pathophysiology, no one has any idea about what vital signs are, what their purpose is, why they're doing it. The problem is it's been taken as a task and it's become a delegated task. So what often gets neglected to mention in the Francis report, it was not registered nurses who had failed the patients, it was the administrators and the nurses who had delegated vital sign taking to healthcare workers, who then failed to understand it, but we all wore it as if it was our problem. It wasn't our problem. The system was the problem, but it wasn't registered nurses. And we all know that many people go through this Gordon's model of unconscious competence, and it's often difficult until you've worked with someone for a while to actually get into their head and work out where it is that they're at. Because, as someone said earlier, we don't want to be at fault, we don't want to be blamed, we don't want to get into trouble, we don't want to admit we don't know. But in fact, in a teaching environment, that if we were really a teaching environment, then it would be okay to say, I don't know. And we need to make sure that that culture remains. So I won't speak more about that, except to say that with the compensatory mechanisms, there's a whole lot of nurses we find who come into postgraduate who've been working for a couple of years on the wards, and they would have 5 years of nursing experience or 4 years, and they can't tell me what the sympathetic nervous system does. So how have they been able to tell how their patient's deteriorating, what the signs are? They can't. So I think it's really important that we actually take every opportunity to reinforce these things to help them put it together. It's really critical. In terms of patient assessment, one of the key things is that we teach pattern recognition and schemas. And schemas are like patterns in your head. So if I said to everyone in this room, septic shock, you can picture that patient. You can actually start to itemise and do a task analysis of what all those signs are. But for a junior nurse watching, if you say septic shock, they won't see that. They'll say, oh, well, the blood pressure was this, and then the heart rate went up, and then they developed a temperature. And it's just these series of isolated things. It's that silo learning that Alex was talking about this morning. We have to work with nurses to put that together. Julie Considine and I have just published a paper in the Journal of Clinical Nursing about using primary survey as the approach to patient assessment. It is the only evidence-based approach to patient assessment that will detect deterioration. So I'd urge you to have a read of that and think about that. And often as nurses, we do have an approach of sort of the temp blood pressure vital sign approach, or we have an approach that's systems based. But if we look at our ED colleagues who are really, really good at patient assessment, they've got a good system that would work well on the wards. The next thing I think we need to really help our colleagues do and teach ward nurses to do is how to then seek out confirming and disconfirming cues. And that's what builds their patterns of recognition. And I think this is what the worried criteria is. It's usually one or two of a confirming cue that they can't put together as a pattern to be able to ring and say, the patient is deteriorating, this is what I can see. But they see bits of it. The role of experiential learning is, I don't think it can be underestimated. All of us know that the more we do something, the better we are at. And it's not just about the psychomotor skill, it's about the theory into practice. So again, it's taking, and ICU liaison nurses are absolutely gold at this. They go into the wards and they work with the nurses and they start explaining what they've just seen, and they put the picture together for them. And they don't miss opportunities to reinforce all of that knowledge. But every one of us can do that, and it would be really useful if we did more and more of it. Again, the pathophysiology of decompensation and compensation needs to be taught, and one way to do that is both through the student or the ward nurses' experiential learning events, but also we need to teach our staff the trajectories of illness and the trajectories of recovery. So, you know, in the really bad old days when I trained, we would have patients on the ward for 5 to 8 days. So I got quite used to seeing patients get better over time with such short lengths of stay, and a model of nursing that is beyond me, where nurses are reallocated to different patients every day. Nurses never actually learn the trajectory of recovery, and they don't learn the trajectory of illness. And this is a really serious problem for when they go to detect deterioration. And situational awareness is critical. So all of this fits in, which you've got to put the patient assessment and the pathophysiology underneath first, but this has to be a part of what we actually teach our nurses. We also have to teach our nurses to have self-insight, and getting them to be reflective is a really important tool. We did a reflection assignment, admittedly in postgrad last semester, and their topic was around Standard 9, and their reflections are absolutely gold. And they've realised problems in the area, they've taken on board their own learning, ways that they can improve it, because we made them, carrot and stick, 20% of their mark, to actually do reflections. And for those of us who are experienced, we do it all the time, but we don't do it often in a way that encourages others to do it. And the tea room used to be a great place for it, but now everyone sits on Facebook. And we've lost all of that. It's a serious problem. We need to teach people their limitations as well. And so that is being able to say, I actually don't know anymore. I think something's wrong and I need to call. There's your worried criteria. On top of all of this is people's scope of practice. So here's the really narky bit. Nurses don't work to their full scope of practice. How is it that Anna was telling us yesterday that the first 3 things, or the top 3 things she's going out to tell nurses to do, is to increase the frequency of vital signs and to put on oxygen, and I can't remember the third thing. That's, I hate to tell you, what we teach in first year nursing. So why is it that these nurses aren't feeling empowered to actually implement actions within their scope of practice? And Ken has said it, and said it earlier yesterday to me. How come nurses collect all this data but don't act on it and haven't been doing so for 200 years? Then that's not every nurse, and I'm probably speaking to the converted here, but it's empowering our colleagues to do this so that we don't have this level of patients deteriorating and they can actually intervene. And oxygen isn't a drug, it doesn't need a medical approval to give it. You just turn it up and give it a bit faster. So teaching people their scope of practice, getting them to work at their level of scope of practice is important, and that brings about performance management and whether we're prepared to make the tough decisions on our colleagues. Teaching people clinical judgment and decision making is critical, and to be able to back their decisions, to stand up and say, yep, this is what I see, this is what's going on. To do that, you have to teach them what authority gradients are, because they kind of know what they are, but they don't quite know what it means. They do know it's intimidating though. And so the communication skills are essential. So here I've given an example, which is PACE, graded assertiveness. Charlie Cork taught me this, and it's absolutely fabulous. So we teach all of our postgrad nurses this, but I'm not sure that it's in our undergrad curriculum. The documentation and tools that we have are forcing people to seek advice, but as it's been said earlier, they're a tool, or they're a screening tool, and they're a prompt. They're not, or a decision aid. They shouldn't be the decision. The decision should be left to the nurse as their own judgment. Putting it all together. Escalation processes, of course, have been put in, again, because people have failed to seek advice. And so what I'd say there, it's really important that people do understand policy and the point of policy, and that point's been made a couple of times today. So all of these things are things that when we're teaching nurses how to actually navigate the system in which they work, these sort of things that are inherent to us are brand new to them. We need to teach it to them. State the obvious. The other problem is the lack of supervision, according to this model. And I'm just going to speak here about the models of care delivery. And one of the greatest concerns is that we have an entire system built up upon a metric of flow rather than quality. Some of you would have heard the last 2 weeks ago the study published in Heart that about 30% of patients with ACS actually get evidence-based care. It's dreadful. We know how to do this, but they might have all gone through ED in 4 hours. But at what cost? So I think if we're really going to actually set up a system that's going to really focus on patients and their families, then let's start looking at quality of care. And that's a really difficult metric. But I reckon if we did quality and evidence-based care, we'd actually save a lot of money. We've got a flatter hierarchy, should make it easier, but it's taken nurses and role models and supervision away from the clinical nurse. This is a serious problem. Primary nursing is a problem. We don't work as a team. There's no one to role model. There's no one to supervise. The skill mix, I've mentioned. We need to protect what an RN does and remove healthcare workers where they are not appropriate. Where they are appropriate, it's fine, but don't delegate a professional role to them. We need to utilise this system processes, and I'm not going to cover that because essentially Jenny did that beautifully for me, because the other slide that I had previously is this. It's exactly that. So you know that very well. Lastly, I'd just like to finish by saying, what should we teach? Patient assessment, physiology, communication, team processes, clinical judgment. Where? Everywhere, in the universities, in the undergrad, in the postgrad, in my hospital, in your hospital, in every single place we are, at every opportunity. And we need to look at who we're doing it for and who's doing the teaching, and that's all of us. And the why is because it's about us, not them. This is our community, and we're the patients as well as the actual deliverers of care. And how should we do this? that's kind of a talk for another day, but one of the things we need to do is embed interprofessional learning and a system that we're highly skilled at our university called team-based learning, where you actually embed teamwork, communication skills along with all your decision making right from the very beginning. Thanks very much.
For more podcasts from ANZICS, go to anzics.com.au.